Hello, everyone.
Hi.
Hi, we're now ready to go to our session 3, which we're going to take a closer look at what the effect of solitary confinement is on, as we put it, both the body and soul.
Body and brain.
Body and brain, sorry. The soul was a Freudian slip, but I guess we can add that. So to take us there is Katti Gray, our journalism coordinator, who has been with us for years and years and years on doing health corrections and prison reporting and justice reporting, and has worked especially on our solitary confinement projects. So Katti, over to you to introduce our esteemed speakers.
Sure. I'm a quick and dirty moderator. My introductions will be short and sweet. The one thing I will say is, as a reporter who has covered both criminal justice and health for years, that health aspects of imprisonment is one of the lesser covered areas, and that it's an area that is critical. People come home, they go into incarceration, sometimes ill, come back perhaps potentially more ill. It's a really critical story for journalists to cover. As I said earlier, most people do come home. I'm delighted about this panel. I will introduce them very briefly. Their extended biographies are in the program. I'm not sure when Dr. Elizabeth Ford sleeps, but she is director of the Mental Health and Criminal Justice Initiatives at Columbia. She is Director of Service for New York City Health and Hospitals Justice Involved Persons Program. She's a member of the Advisory Council of the Correctional Association of New York, and is or was Chief Medical Officer for the Center for Alternative Sentencing and Employment Services. That is indicative of what her bent is medically and politically, perhaps. She's a psychiatrist. Dr. Mariposa McCall, as well, is a psychiatrist. She is an expert witness in the area of corrections. She practiced formally for the California Department of Corrections at Pelican Bay and San Quentin prisons, whose conditions have very much been the drivers of much of the reform in that state. We also have Pamela Winn, a registered nurse. Before she was founder and executive director of Restore Her, she spent some time in federal prison where she miscarried during incarceration. I'm delighted, Ms. Winn, that you would come and tell your story as well. Dr. McCall and Dr. Ford, the same. Dr. Ford, will let you take it away. Thank you.
Oh, thank you, Katti. I appreciate that. In full disclosure, I am a last-minute replacement on this panel, although very happy to be here, and did just want to, I guess, amend my bio a little bit. I think my primary area of expertise with respect to this panel is that I was the chief of psychiatry in the New York City jail system for 6 years. Left coincidentally, serendipitously, I don't know how to frame it, but just a couple of weeks before the pandemic in early 2020. And my and for my 20-year career, I've been largely focused on the care of people with serious mental illness who have been incarcerated or have experienced incarceration. So most recently, caring for people on probation and parole. Unfortunately, although a lesser number, at least in New York City, but unfortunately, many of them have experienced solitary confinement, whether called that or not. So I hope that in part of this conversation, we'll get into how it's defined, but then also how it's actually practiced without being called solitary confinement, because that's, I think, an important piece around practices in these sort of hidden spaces. And so maybe I'm not exactly sure which direction you want me to head. I can just keep talking, which is probably not what you want me to do.
All right. A riff is always good here. Reporters love folks who do that. So just follow whatever is your stream of consciousness. That's fine.
Oh, okay. Well, I'll do that for a few minutes and then maybe Pamela or Mariposa, I'll send it to you. So, I mean, I think I have unfortunately not been able to hear the conversation that's happened so far today, but one thing struck to me on the agenda was a bill to fund more research about solitary confinement. I saw that that was in the program. And I think one of the things I would like to highlight is that we really don't know, like we do not know the full impact of what the practice of confining people who are already confined has on mental health and any kind of large population level. I can certainly tell you what the research shows that with respect to small samples, with respect to research that's done in the form of, that comes through litigation, which is biased in particular ways, research that relates to people who are incarcerated, not just in solitary confinement, has significant restrictions through the federal government, which I think are in place for very important reasons, but that also have made the true understanding of the impact on an individual's mental health difficult to ascertain. So I just wanted to sort of start off with whatever I have seen and cared for in the patient population I've taken care of in New York City. That's anecdotal largely, and the information that was reported out, at least that I see in the news, largely also is anecdotal. So there are many horrific individual stories that are a result of solitary confinement. I think if we're going to have a meaningful impact on the practice as a whole, we need more. We need a better understanding of it, and we need an understanding that crosses institutions, right? So the way it's practiced in New York City is much different than the way it's practiced in Colorado, probably in California, and like it's such a different practice. So I want to say that also that I think some of the things that are not, by the way, I'm thinking like if this is largely a journalist audience, you're thinking about what to write about. But I mean, Katti, you brought up that healthcare, like, and the health impact of this practice. I think there are certain areas that are focused on, at least in my profession, for example, suicide and that impact. I think what's less discussed but that I see all the time are the long-term consequence, like the impact on a person's. I know in the introduction, Stephen said soul instead of brain. I actually think that however one defines soul, there's a long-lasting and very challenging impact on it. Just in the way an individual sees the world, the way they interact with the world. I think it can be very complicated coming out of solitary, even just into a general correctional setting, much less. There are people who are released from solitary confinement and then right out into the community, and that transition is extraordinarily jarring. But I don't think we talk enough about what happens to a person's brain when they are under chronic stress, like it's not letting up at all for years, and isolated, unable to, and with a lack of access to the thoughts and behaviors of other people. So we're social beings, right? So to not be able to reflect how you feel against another person's opinion or thoughts is extraordinarily damaging, and it can make it very, now I see people who are coming out of that system, very hard to then navigate, the way the United States has created our society. And so I don't think that those are, I don't know. I think they're dramatic. Maybe they're not like the dramatic, newsworthy health things that people write about, but at least in my work, it's sort of the loss of one's ability to be autonomous that is extraordinarily damaging. And I am going to stop there for the moment. And I guess, should I turn it over to Pamela or Mariposa?
Dr. McCall, we're going in alphabetical order. So Dr. McCall. You're muted, I think, still.
You're right. Thank you. Thank you for inviting me to participate in this panel. Let's see. So I've been practicing since 2003 when I finished residency, and I've been largely working in nonprofits with community underserved communities, largely African American, monolingual Spanish. Yeah, I got offered a position to work at San Quentin as a contractor back in 2010. And I really hesitated to take that job because I was thinking, God, I don't have training in corrections. My residency one didn't offer rotations in that, although I could have requested that. Yeah, and I really hesitated to take the job because I thought, okay, I don't know if I can do this. I'm here, been working, for 7-8 years at this point with the community settings that mostly treats the victims of crime. I felt, a lot of trauma in the clinics, and I didn't think that I could, sit before the perpetrator. And it was, I took the leap and I challenged myself and I went to San Quentin, and it was the most transformative experience to this day that I've had. Before me were victims. Oftentimes they have a trauma history, and listening to them and taking off layers of their story and their narrative and the struggles that they had before they went into prison, while they're in prison, you start seeing the person and not, the person that got incarcerated with the crimes and everything. And it just really taught me, to hold my judgments and really just be with someone in their bare essence. And it was the greatest gift that I've had, being before someone, just to see their humanity. And it was just so amazing. And as a contractor, I would have stayed longer and I would have converted over to a CDCR employee. However, there was the big, huge realignment brought over by the courts that said California is tremendously overcrowded, and that is compromising care. And so they started shifting folks from the prison systems to county and jail, and a lot of people were getting let go. And they thought that they didn't need any more contractors, which is a big mistake. So they let go of all the psychiatrists, and that's how I ended up going back to the county system or another nonprofit, I forget. But yeah, I left with, and I was in San Quentin. So San Quentin is a different setting because it's in an area where there's a lot of volunteers, a lot of programming. So I think that impacted to my experience in corrections, which was a positive experience. Then I returned to CDCR, California Department of Corrections, in 2014 I got offered a telepsychiatry position. And at that point, I didn't know exactly where I would be assigned when I took the offer by the same supervisor I had in San Quentin. So he hired me, and I got assigned to Pelican Bay. So Pelican Bay is known as the worst of the, prison for the worst of the worst. A lot of that rhetoric, and they got there because they earned it to get there. So it was this kind of mentality. But again, working with those individuals didn't seem too different than the people that I was working in San Quentin, which is a low maximum security prison. But that experience, that second experience was an eye opener in a different way. And that has led me to share that story and working with people that were coming out of solitary confinement and their experiences. I didn't work in the solitary confinement unit in the SHU, but I often worked with the individuals that were released and heard their stories and the impact and the dynamics between the inmates and the corrections and the people incarcerated and their perceptions of the clinical staff, and all that dynamic was very powerful. So I hope that I can bring some perspective, I guess, to what happens behind those walls. I had no idea. And I think a lot of people don't. When I came out, I just felt like at any opportunity I had, like in my own work experiences, to tell my coworkers, say, do you know what this is, what's happening? We're seeing these people that are coming out of prison, we're seeing them in our clinic, and we need to know that history because it's impacting them now. And if we don't understand that, if we don't dwell into it, I think the outcomes are not going to be as effective. So that's right now, currently I'm at the VA, and that that has also given me a different perspective because now I'm working with folks that are the correctional officers. So now I get to hear their stories because a lot of our veterans take positions that are very similar to their training in the correctional field. And so now I'm getting more of a balanced view, I guess. And I really appreciate that aspect too of where I'm at in my career too. I'll just leave it at that. Thank you.
Thank you so much. Ms. Winn, please.
How are you all doing? I'm Pamela Winn, founder of Restore Her, based here in Atlanta, Georgia. I appreciate you, Katti, for having me on today. And listening to the three of you, I was able to relate to a number of things. As Katti said, the health aspects are not prevalent as they should be. Folks are really not aware of a lot of these things, along with the myths of why folks are in solitary confinement. And along with that, as Dr. Ford said, the numerous names. So speaking of myths and names, when we think about those things, you would think a person that's in solitary confinement that has to be in isolation away from everyone else must have done some horrific thing. And in most cases, that's definitely not the case. So when we think about that and we're thinking about all of the different names, for myself, we can start with medical observation, which means no, that I did not do anything horrendous. I did not do anything wrong. They claim I was there for medical observation, for them to observe me because I was pregnant and I was experiencing complications with my pregnancy due to shackling, which caused me to fall. And so in those cases, we're talking about putting a person at risk, basically in torturous conditions for a medical, a medical problem, which sounds ludicrous, but it's something that we do on a regular basis here in America to not just myself, but hundreds of women that are incarcerated in the system. Along with those other names, I was also placed in solitary for quote unquote protective reasons because I was sent to a facility that housed local incarcerated folks, and I was federal. And so per the contract, they could not allow me to be harmed or damage the federal property. So in order to make sure that happened, I was isolated in solitary and kept away from other folks to make sure that they didn't try to harm me or fight me or anything like that to maintain the obligations of a contract. So these are just, like I say, some of the things that people are put in solitary confinement for and are damaged on a long-term basis for something as trivial as these things. And it gets even more trivial than that. You can have more pencils than you're supposed to in your cell, or if you're issued 3 t-shirts and you have 4, that can get you placed in solitary confinement. And again, the other names, the box, the shoe, administrative segregation. There are so many names. So for me, one of the things that is critical for eliminating solitary confinement is that we must come up with a very descriptive but general definition of what solitary is, because there are so many names and there are so many reasons that folks are placed into solitary. And again, myself, I was a registered nurse prior to my incarceration. I am from the South, from Atlanta, Georgia, which means that I come from a typical Black Southern family, that being uneducated and low income. And because of that, I was a first generation high school graduate, college graduate, entrepreneur. And in that, owning my own business, there was no one from my environment to guide me or give me advice on how to run my business, which caused me to make poor business decisions, which landed me a 78-month federal sentence for white collar crime, and which I found out that I was pregnant. During that time, I was not given a bond. So the things that happened to me occurred while I was in a holding facility. At this point, I had not been convicted. I had not been sentenced, but I was placed in solitary confinement for 8 months for what we said, medical observation and protective custody of other folks that had a different status than I did, incarcerated. Each time I was taken out to court, so I was going to court on a regular basis because I had not been sentenced at this point or convicted, and I was shackled each time I was taken out, which was, for folks that don't know what shackling is, a double chain wrapped around my belly that connected to wrist cuffs in front of me with a black box, which means that my motion and movement was very contained only to the front of myself. And then I also had ankle shackles, which were cuffs on each ankle that were connected by a chain in between my legs, which made it very difficult for me to walk. And with handcuffs, the way they're designed, the more you move, the tighter that they get. So with each step I would take, those ankle cuffs would tighten up on my ankles. And one of those days, they had literally broken the skin on my ankle, and trying to step into the van, I slipped and fell because of the pain, the excruciating pain. And falling was like a tree falling, because again, I am shackled, chained down, so I couldn't reach my hands out to brace my fall. It was a hard fall to the ground. And when I fell, there was no even asking me, was I okay? I just had 2 officers scoop me up from each side, placed me on the van, and took me onto court like business as usual. And even returning, I was not asked, was I okay? I was not given a medical examination, none of those things. I began spotting, eventually actively bleeding. I wrote requests for over 2 months that went unanswered. Finally, when I did get a response back, I was told it was normal with pregnancy. My response back, I told them all of my credentials and that I had been an RN that specialized in women's health. And based on all of my medical knowledge, as well as my professional experience, there was nothing normal about what was going on with me. At that point, they did bring me to medical, the medical director, and then the physician contracting at that time set me down as a quote unquote professional courtesy to let me know that there was nothing that they could do for me, that that facility was built for men. They didn't expect to have women, and they definitely did not expect to have a pregnant woman. And the best that I could do was to hope that the prosecutors would allow me to bond out, because they couldn't even offer me a prenatal vitamin. So I did not ever receive any medical care, even just to take me out to be seen, because they didn't have a contract with any obstetrician meant that they had to send a request to the U.S. Marshals and wait for approval. And the turnaround time for that was 4 weeks. So they sent a number of 4 requests, which a total of 16 weeks. And I just was not able to hold on and ended up miscarrying my baby. And so, like I say, each time, you know, I sat in medical observation in solitary for them to just watch me, because they had already told me that there was nothing that they could do for me. And during my miscarriage, I was still shackled to the bed by my ankle and wrist. I mean, my ankle, yes, ankle and wrist, where I endured that miscarriage.
Pamela.
Yes.
Pamela, let me interrupt you a second. We're going to come back to some of this. We want to maximize the time for questions. So hold on to some of that and we're going to come back. Okay, thank you very much. If we can start here before getting back to, and I'm going to first names. I'm a Southern chick, so y'all are Dr., Miss until I get to the other thing. So Elizabeth and Mariposa, even if the research is incomplete, and I've seen some of the research, anecdotally, quantitatively, or qualitatively, something, what are the health effects of being in solitary, whether long-term or short-term? What have y'all seen? And what should journalists follow? And if there's some research that is more complete than the other, I'd love that citation so we can include it in our resources. And if you're not muted during the discussion, we're getting a little feedback. If you can mute when you're not talking, thank you.
Okay, Mariposa, I guess I'll start unless, so in terms of a reference, there was an article published in 2020 that's a review of all of the studies of mental health and solitary confinement. And that I can send you that citation. I'm not skilled enough to put it in the chat, but it's in the International Journal of Nursing, I think. Anyways, I can send that to you. That actually reviews the studies that meet a certain criteria for rigor in terms of this. So that might be helpful. What I have seen in terms of the mental health effects of solitary confinement include frankly, like the whole range of symptoms that you could imagine, from anxiety that's minor to anxiety that's so severe it's debilitating and the person can't sleep at all despite medication. Mood symptoms, which can run the range of feeling sad to being so depressed that they stop eating or sleeping and attempt to kill themselves or do. Thought symptoms. So the way we think, like, in full disclosure, I don't love the way psychiatrists label things. So I'm just going to sort of describe, but thought patterns that are difficult to follow and that may be influenced by sort of perceiving things that are not there. And I personally have not ever seen somebody actively hallucinate for long periods of time, but I have certainly seen hallucinations and perceptual disturbances that are short-lived for people who have been in extended periods of solitary confinement. I think there's if I could put it into two broad categories, I feel like there are these extreme responses in terms of behavior. One, passivity. So like just being confined like that and sort of losing all ability to advocate for oneself, feeling helpless, hopeless, like not trying for oneself. And then on the other extreme, this like incredible anger and rage, which to me is quite justified, but that sort of leaves the person continually pushing up again, literally and figuratively, against that cell door. And the impact of both of those extremes on a person's mental health are pretty significant. I would also just add that access to care, so just access to medical and mental health care when someone's in solitary confinement is difficult. And even though people have rights and are entitled to that care, when people are confined in the kind of way that they are medical care sometimes is a lower priority than security interests. And so access to care can also certainly harm health in all sorts of ways, right? If somebody doesn't get the care that they need. I just wanted to add one other thing, and then Mariposa for you. Pamela, you were talking about medical observation and sort of that. It also happens with suicide prevention in a lot of places. It's not in New York City, but many correctional settings, the answer to suicide prevention is to take someone's clothing, give them a smock that looks like a moving blanket, and put them in solitary confinement, but it is called something else. And I hope that the audience can imagine that's not, while that may prevent the person from actually killing themselves in that moment. I would argue, and there's not research for this, but I would love to be that, I would argue that increases their risk of eventual suicide after being released. But there's no research to prove that yet.
So,
Mariposa, as you give your answer, would you also talk more about the bodily manifestations as you saw them? And then Pamela, take that up for you, okay?
I'm going to kind of preface the damage that this type of housing designation can do. I mean, any person who is placed in a very taxing environment is going to have a physiological response of excessive, the stress response will be triggered. There's going to be tremendous cortisol that will be released that can then lead to elevations in blood pressure and inflammation. And it cascades into a multitude of other problems that could affect the control of the blood sugar and all sorts of things, damage to the arteries, leading to heart attacks, brain. I mean, the stress response is quite underappreciated. And when you're confined in a box of 8 by 10 for 23 hours with minimal human interaction, meaningful human interaction, and sensory deprivation, but at the same time overly stimulated with lights that are on 24/7 and noises that are reverberating against these concrete walls, it does something to you. Even if you do not have a mental health condition going in, it's going to change you. There's no one that I've spoken with that has come out unscathed from this placement. And while the evidence is anecdotal, it is powerful. People who don't have a mental health condition report the beginning of an anxiety and being closed in and anxious. Thought process becomes more difficult to kind of maneuver. It's they distracted or become obsessive about things. They start feeling depressed to the point sometimes of feeling hopeless or helpless and even thinking suicide. It's not uncommon, and it's tons of studies have shown that the highest rate of suicide, not just attempts, they occur in these segregated units. Over 50%, I forget that, I mean, there's so many studies that have shown this, and self-injurious behavior is off the roof. That's even greater. There's a desperation that happens, and the bad thing is that, one, Elizabeth, she's right that the access to getting care is quite limited. It's compounded. It's harder to access care. You can file a request to be seen, but you may not get seen, and you might get seen by a psych tech rather than someone that could help. The other is, and I think this is an underappreciated thing. People do not trust the clinical staff. Okay? They often feel like they're in the cahoots with the correction, and that anything they say is going to be used against them in parole hearings and other settings. And so even though they're going through it, they will not seek help that they need. It's a really sad bind that they are in. And the people that do best are people that can early on try to find a routine that then becomes obsessive and compulsive, and then they carry that out. But if they can develop a routine that can occupy their mind and their body, they can possibly survive this. And I mean survive, because once they leave that setting, they carry all of that outside into the general population or into our communities. And that could be that they have difficulty engaging with people, because after months or years of being isolated, they lose the interpersonal skills that maybe were already challenged to begin with. And they become more isolated, or and then if someone has a mental health condition, going into this setting is just horrendous. Nobody with a mental health condition should be placed in a situation like this, because everything gets exacerbated, and you just can't treat a condition. The setting is removing someone from that setting is the treatment. A pill is not going to treat it.
Mariposa, thank you so much. Elizabeth, I just sent you a question in the chat. Pamela Winn, we're going to move to you to answer that question. And I want to add to it a question from David Dudley, one of our journalist fellows. He says, would you please use broad strokes to describe your experience in solitary? How did you pass the hours and the days? What did you do? And I'll add to that, how do you continue to live, if you will, if you do body, soul, brain with that experience?
So I was placed in solitary confinement immediately after I miscarried my baby. And so the first few days, I guess it was, because I don't have a custody time, I would say that I just replayed those moments over and over in my head of what had just happened to me. The whole process of, being in a cell, feeling the blood, trickling between, just the whole scenario would just play over and over in my head. And of course, that would just keep me upset and crying the entire time, feeling like, as Dr. Ford said, hopeless and helpless, that there was nothing I could do for myself in this space, because of course I can't get out. I'm at the will of whomever comes by to check on me when they decide. You may not get that 1 hour out, depending on the discretion of the officer or what their staffing looks like that day. And you just have to deal with that. So yes, feeling hopeless, feeling helpless. I was a professional before I left, so lots of feeling of failure. And I also had 2 sons at home that I also was feeling like I had failed. A lot of shame, a lot of embarrassment to deal with. I would spend most time just thinking of my sons. What were they doing? What were they feeling? Things I wanted to do with them when I got home, placing myself in places like putting myself on the beach, feeling, and trying to feel my toes in the sand and what the water felt like on me. Speaking out loud, everything in my head, calling out streets, calling out people, so I would not forget anything, because I noticed that I would have a train of thought and then I would lose it. And so it made me feel like I was losing my thoughts. And so I would actively every day just go through the timetables, call out every street that I know, trying to maintain my thoughts, maintain my brain, you know, just anything that was important to me that was in my head. The light and the dark, it was like, seemed like the lights were always on and bright when I wanted them to be off, when I was tired of sleeping and wanted to go sleep. And then it was always dark when I was wide awake and wanted lights to be on. Then just praying that I could go to sleep and that when I woke up, it would be the next day. When I did wake up, I didn't know if it was the next day or not, because there are no windows, there are no clocks. You don't, you know, I didn't have a clue of what time it was or even how long I had been there, unless, you know, when someone came around, I asked them, what's today or what time is it? You know, if they told me. Hearing screams of all of the other people that were there on the floor in solitary, just screaming around me, trying to block that noise out of my head. I am thankful that I did have a medical background because I was able to recognize things on a medical level. And when I recognized them, I knew I had the skills and the tools to do things to try and counteract that. But even in that, I still right now today suffer very, very much with social isolation. It's very difficult for me to interact with folks. I prefer to be alone because that's most comfortable with me, for me, because then I don't have to be challenged with, you know, keeping up a conversation or, you know, or appearing to be there when really I'm not there, you know. Even when I sleep, my bed, I sleep in one spot, one corner of my bed. The rest of the bed is just my computer, you know, things on the bed. I don't really move. I stay in that one spot. I have a granddaughter, and this is most hurtful to me. She's 1. When I'm with her, I don't really know how to interact with her in a way that I should. And I have 2 sons. I raised 2 kids. So I know that I know these things, but now, you know, from the experience, I don't really know what to do. A lot of times I just sit there and I watch her, and in my head, I wish I could, you know, interact with her and play with her the way that she wants me to, needs me to, but it's just not there. And so depression, I get depressed a lot. Matter of fact, I've just been fighting it over the last couple of days. And it's surprising to people because when you look at my bio, you see all the accolades. It's like, what are you depressed about? Well, I'm depressed about because I recognize that I have issues with social interactions, and it makes it hard to be in relationships because I can be present there with them, or if you, but then I want to be away. I need, you know, I need that time to myself because I guess overstimulated when I'm constantly around someone, including my family. And that's very hurtful because it makes my friends and my family feel like I don't want to be bothered with them, but that's not what it is.
Pamela, thank you for the generosity of that answer and for your vulnerability. I appreciate it. We're gonna move to some of these other questions. This is from Clark Merrifield. Is there one, and this is an open question, Clark says, is there one thing you wish reporters would do right that we sometimes seem to miss or get wrong when it comes to how solitary confinement affects the mind and body? Elizabeth, you want to jump in first?
Well, I saw that question in the Q&A, and I don't know that I have maybe I shouldn't. I mean, I see what I have seen reported generally aligns with what patients I've taken care of have also described. I think some of the long-term consequences, like Pamela was just describing, are not well described and are not described in a way that a reader who has never experienced that kind of situation can understand and can empathize with. So maybe that would be my answer.
Pamela, Mariposa, go ahead. I'm sorry.
I think one missing component, I know, we're talking about the direct impact on the person who's confined, but I also think that what is not talked about is the ethical dilemmas that clinical staff must grapple with when they are assessing these human beings in these inhumane conditions. What it does to them is profound. There's moral injury that happens in the sense that we go into this profession hoping to help people. And what we are then asked to do in these settings goes against ethical values of human dignity and human rights. And clinical staff is being asked to clear people, to go into these horrendous, we know is damaging setting. That needs to be magnified. And what are our organizations, like American Psychiatric Association, our American Psychological Association, the National Social Workers Association, what are they actively doing to support the clinicians and also bring really their voice and their influence to highlight the damage that this is doing to our profession on an individual basis as an organization, and also the damage that it does to the perception of the patients that we are supposed to be caring for and advocating for, and how we fail to get them out of those horrible, inhumane situations. We're almost legitimizing this practice and just going to see them and knowing that we can't help them, that we can advocate. We can say, oh, get them out. They're doing worse. They're decompensating. And that's not being honored by corrections, or we're afraid. We're afraid to say, get them out of there now, because we fear retaliation, not only from our supervisors, but also from corrections, because if we stand up, who's going to watch our back? So that needs to be highlighted. The other component is the correction, the impact that this has on another human being, to place someone in conditions like that. I hear now that I'm working at the VA, and I hear the stories and the struggles that these correctional officers sometimes have to deal with, the choices that they have to do and oversee people in these conditions really also traumatizes them. So those two things I think are missing in this discussion. And if we can include these two, I think we could have a more unified force to make collective action.
Thank you for that. Pamela, you have had your share of media coverage.
Yes.
What's correct about it? What contextually perhaps is lacking in that coverage?
Okay.
And what do reporters get right, for that matter, regarding your story?
Well, for me, what they get right is they print what I say, because I make sure I advocate for myself that the words that I say are the words that are printed and the words that are, released through me. What gets wrong for me is when everything is provided on a contextual basis, where the language is not humanizing the folks, but it's just a general context of what happens with solitary. The language needs to be more humanizing. Make sure that when you're speaking, you're making it clear that this person is a human being. Because like I said earlier, there are so many myths about what person is placed into solitary when we know that most of the people, I'm gonna say at least 90% or more, have not done anything horrific to be in solitary confinement. So I think those things need to be highlighted. Those things need to be, put out there on the front page, that these things are happening, and humanize the stories that you put out more so people understand that, this is a human being, not some crazy person that's done some deranged stuff. And as Dr. McCall said, we pledge an ethical oath when we take these positions. Call those folks out on not upholding that pledge that we take, are the things that I would say.
I'd like to ask you this as sort of a preface to a question that was here that might have disappeared. How marked was the difference between your mental and emotional state before you were incarcerated and then while you were incarcerated? How marked was that difference?
Okay, so that's actually a good question. So the first time I ever spoke about my condition, my thoughts in a summary was, I left whole and I came back in pieces. And that is the basis of the name of my reorganization, Restore Her, because since I've been home, I've been trying to restore myself. And if you can see behind me, my logo, you see it's a lady with puzzle pieces. That's how I feel. I was a whole puzzle. I was a whole piece. When I left here, I came back in broken pieces that I'm now trying to put back together. I had no health issues. Now, as a result of being in there, and this happened while I was there, and Dr. McCall spoke about it, I have high blood pressure now. I have the social. Before I went in, I was a very social person. I lived a very active life, amongst things. That has changed now. As I said, I prefer to be alone. It's more comfortable to me because I don't have to have the challenge of keeping up the conversations and doing anything. I feel detached, I guess, is the best way to describe the difference between who I was before I left and who I am now. Before I left, I had these same accolades pretty much before I left. As for where, I was accomplished. I was an RN. I specialized in women's health. I was a homeowner. I was a business owner. I was all of the things that we aspire to be. So I was that person. And now I still have the same accolades, but I feel completely detached to, everything and everyone, in that sense. I don't feel whole.
Thank you for that. Elizabeth and Mariposa, what kind of research exists about particularly mental distress that solitary confinement triggers? I mean, what percentage of people, if you will, if there's a number to get at, who go in solitary suffer this sort of acute mental distress?
Gosh, I don't know if we have that. That's why I think the research is going to be so important to do. At the same time, I guess I'll play devil's. I just worry about the research and the duration and how long it's going to take before action is taken. We don't know. I mean, what I saw from California, Dr. Haney, a social psychologist, he did a work with the Pelican Bay hunger strike lawsuit. And I mean, he was quoting like 79% of the people that were in solitary continued to have, symptoms from that placement. And I know that in 2017, the Stanford University, what is it, the Human Rights and Trauma Mental Health Lab, they studied folks that had been released from solitary 14 months afterwards, and a huge percentage, I can't quote at the percentage, but a lot of them still struggled with a lot of emotional issues, thought process, and so it's an impact. It's traumatizing. And you know, listening to Pamela, I know she mentioned depression, but this is PTSD. This is what happens with people who have been traumatized. There's a disconnect between themselves and the world, and even from themselves. So there's a lot of detachment, and trust issues is huge. And it's something that is preventable. This is a preventable harm that we as a nation need to eliminate. Yeah.
Elizabeth, do you want to weigh in on that? We obviously went over it. We have one more question, and then I'm going to give y'all a chance to whip around and have a last word. But Elizabeth, do you want to weigh in on that?
Well, I agree with Mariposa. I would just also add that I do think we could know the answer to this if systems were transparent about their practices and their data. That's a huge problem in this work. So based on the state and the county that you're in, jails or prisons may or may not have the requirement to reveal data. I mean, this is right, security data from their perspective. And so, but if there was more data transparency, I think we could know the answer to that. However, there is still a catch, which is that the way mental illness and mental health disorders are defined in jails and prisons is totally different also. So there isn't, like, if you're going to do any research, it's the only way it's reliable and valid is if you're, you know, comparing apples to apples. That's a terrible analogy, but you should be talking about the same thing. And because, you know, these systems are very closed and isolated, and there has been limited, in my opinion, public and political interest in actually getting in there and really understanding what's going on outside of a lawsuit or outside of a class action. And when you bring legal players into a health problem, then you get, you know, there's just a lot of bias. People are hired by each side of the, I know Mariposa does expert work. I used to, you know, there are different opinions based on where you're, so I do. So anyways, I agree that we don't really know. I do think there are ways to find that answer out, but there's got to be some significant political and public will to do that. I don't know that this country, frankly, like, cares enough at this moment. Sorry to say that, but I just don't know.
I'm going to ask one quick question of the doctors before I get to a last question to Pamela. If you are in solitary confinement, do you only get medical care if you have an acute emergency condition, or what?
Well, it depends on the system. In New York City, you get access to routine medical care for conditions that you have, like, for example, high blood pressure or diabetes, and you get access to routine and acute mental health care as well. It's across jurisdictions, it varies.
Mariposa?
So for, yeah, I mean, everybody's entitled to medical and mental health. They have to request it. So if someone doesn't have a diagnosable kind of mental health condition, they will not be seen by mental health, or likewise for medical. So I guess the first step is identifying yourself, right? Requesting, or someone identifying you as having a mental health condition for you to get services. Like I said earlier, people in prison often, one, distrust the clinical staff, so they don't ask for help, or two, they feel they can't ask for help because what will it look like in there with their peers? They can appear weak, or And so that there's a lot of barriers to accessing or getting the help that sometimes they know they need, but they hold on and hold on and hold on until they can't. And then something bad, tragic happens. So yeah, everybody can have mental health. However, you know, if they don't have a diagnosis, they're not going to be routinely brought in for a checkup.
Thank you for that. So I'm going to do two things here. Pamela, I'm going to give you this last question. And then if you would take a moment to sort of provide us with your short wish list of coverage, if you will. And Elizabeth and Mariposa as well, if you want to give some sort of parting comments, anything that you've talked about, or especially that you've not talked about that you think reporters ought to keep an eye on. Pamela, please. I'm sorry. Here's the question. I'm sorry. And this is from Wista Johnson. What kind of support or treatment have you received? What's realistically available for others who are presumably reentering with fewer sources just to help with the work?
Okay. So the treatment that I received, I was fortunate enough to have made a connection, professional connection with someone that had a friend that's a therapist that agreed to see me for no charge. So I'm able to speak with her as often as I need to. However, this is not something that's readily available for people when they come home. You don't come home with insurance. A lot of times it's hard to get insurance because you have a background. So most people don't get the care that they need. So I was just fortunate in my situation to receive it. So that's something else that I advocate for, that folks, and even like I said, I developed high blood pressure in there being under the consistent stress at all times. And even that, this is something that happens to most people in there based on, the food, the conditions, staying continuously under stress, all of that. And then you come home, you don't have the money, the bandwidth of anything to properly take care of your health issues. So something that we advocate is providing some type of public health care or something, or if folks can be sent home with medications that, they are taking while they are there, they send them home with at least a 3-month supply until they're able to do some things for themselves, because that is also a big problem, along with data. Data collection is a big issue. As Dr. Ford keeps stating, I'm actually scheduled, and I'm saying scheduled because of the weather down here in the South, to have an inaugural research conference on Friday, September the 30th. And this conference is to bring focus around the need and the awareness of the lack of data collection for incarcerated women. There is little to none. My good friend, Carolyn Suffering, has pretty much the only data, and it's kind of outdated, and it was done in 2017 for incarcerated pregnant women. So I definitely work on, and like you were saying, Dr. Ford, they don't want to give us access. So I have started my own research program. Is Data is Life, because data access, transparency, and accountability is life for incarcerated women. And we need that data. And every bill that I have passed, and right now I'm at 21 state bills that ban solitary confinement for incarcerated pregnant women. Also, I was fortunate enough to be able to write the women's language in the First Step Act that also bans solitary confinement for incarcerated pregnant women. And based on that, every piece of legislation that I draft has data collection in it, and I am always fought by the sheriffs to have it removed. They don't want to give it to us because it will hold them liable, and it will create a picture that they can't deflect from. So the conference is provided to bring awareness to that, also to get more directly impacted women interested in data collection, because having the experience of being inside, we have alternate means of getting data that most academia folks and medical professionals do not, because we know the ins and out, and we're still in communication with many of the folks that are still inside. So we can get data collection a lot easier than you all can. So I'm trying to inspire more directly impacted people to get on board about getting that data, because that is what I think would be a major factor in getting some things done, if we could have the actual factual data to support these things that we talk about on a regular basis. And other than that, we have our new legislation, the Women's Care Act, which will defer a pregnant woman's sentence until 12 weeks after she delivers, will be in session this upcoming session. You're muted, Katie.
Thank you. Thank you so much, Pamela. Elizabeth and Mariposa, 15 seconds, last words. Thank you.
Limitations with data is how it's manipulated sometimes. So not to throw a wrench there. But the other is, I mean, the cultural shifts change. The cultural inside needs to change. I know it's a huge reflection of our society and the tensions between different races and people of authority. But I think if we don't look at the culture and how the dynamics between interactions between people, different people, if we don't include people that are incarcerated in the discussions about the changes, and everybody, all the stakeholders, I think people are going to drag their feet. They're going to haphazardly implement things, and it's not going to be as effective as we hope it to be. It's going to possibly just be a setup for failure, and then a justification for continuing the status quo.
Okay, 15 seconds. I would like to see more FOIL requests for data around why people are going into solitary confinement, and 2, real conversations about alternatives to solitary confinement that include people who are proponents of it, so that there can be a meaningful, durable change that everyone can support, because I know those exist.
Thank you. Steve's got it.
Yeah, thank you, Katti. We still have some questions in the bank, but what we'll do is, again, as with the last session, we will pass them on afterwards to our speakers, and if they can answer them, and then we'll pass them on to you guys so you have the answers. But as you've noticed, we've gone a little bit over our schedule, but I'm sure none of you will mind. It's been an enthralling, really absorbing discussion. I want to thank all of you for the time and really for the courage in talking about these really, really difficult issues. So thank you, Katti, for leading us through it. And Dr. McCall and Dr. Ford, especially for coming, and Dr. Ford, especially for coming on at the last minute. You were perfect. And Pamela, thank you so much for sharing what's been a really difficult period of time for you. We'll take a quick 10-minute break. Our next session and the last one for the day will be a little bit shorter than what's on our schedule. So we will still hope to end as close as we can to our scheduled time. So well, instead of 4:50, we'll probably end a little bit about 5:15 or 5:30. So I hope you can stay with us. But once again, thank you all. Thank you very much. And we'll take a 10-minute break right now.